Welcome, everyone. Thank you for taking the time to join our call today. Did you know that more than 50 million kids are out of school in America right now? This is such a challenging statistic for every family, but it's even more challenging for families who are dealing with issues like homelessness or hunger or unemployment. I'm Anna Bob. I'm the health director for the Philanthropy Roundtable, and we're gathered today to learn from a group of people who are really focused on reversing the adverse effects of COVID on kids. And they're focused on solutions that we can implement right now. We're going to hear from each of our guests in turn, and we're also going to be taking questions throughout the call. So if you have a question, please use the Zoom question and answer feature, which is at the bottom of your screen. Just type your questions as we go, and we're going to address them to the speakers as they come in. We're also going to reserve time at the end of our time together for a broader time of comments and questions. So our guests today, who I'm excited to introduce to you, we first have Dr. Gary Blau. Gary is a licensed clinical psychologist. He's the executive director of the Hackett Center for Mental Health. The Hackett Center was formed by a transformative $20 million gift made by Maureen and Jim Hackett in 2018. The gift was made after Hurricane Harvey, and the Hacketts were really concerned about the level of trauma children were experiencing due to this crisis. And even more, they were really concerned about the trauma, the way that this crisis had triggered trauma that some of these children had actually been experiencing long before. And this really was what stimulated them to create this center. They then, as they developed the center, they made a really landmark hire in recruiting Dr. Blau from the Substance Abuse and Mental Health Services Administration, which we affectionately call SAMHSA or SAMTA, or I don't know what it's a federal agency where he was the chief of children, adolescents, and family branch there. And he provided national leadership around children, adolescents, and young adult and their mental health. And he also was focused on creating systems of care and cataloging best practices in these areas, really across the United States. So he's a national expert in these issues. Also joining us from Boston is a psychiatrist and associate professor at Harvard Medical School, who's also the founder and director of a nonprofit called Think Kids. This is a nonprofit that's based out of Massachusetts General Hospital, and it provides online training and parenting groups in a method called the collaborative problem-solving approach, which we're going to learn more about. And all of the programs that they have created, or many of them, are online. In addition to this, Dr. Adlon is a speaker, a well-regarded speaker and writer. His books include Changeable, The School Discipline Fix, Treating Explosive Kids, and Collaborative Problem Solving. We're also delighted to be joined by Dr. Rashni Kohli, who is a child and adolescent psychiatrist and the medical director for pediatric mental health services for Dell Children's Medical Center. Among her other achievements, Dr. Kohli has been instrumental in developing the Texas Child Health Access Through Telemedicine program, which she's also going to tell us about today. So now let's start our conversation with these wonderful guests. Dr. Blau, I'll turn it to you.
Great, thank you so much. And thank you all so much for joining the call. Let me first start off by saying that I hope that you and your coworkers, your families, your friends are all well during this pretty amazing and unprecedented time. I am very honored that I have an opportunity to speak with you today and to talk about ways that philanthropy can partner with so many others to make a difference. I will say that we've already seen philanthropy stepping up in so many different areas. Obviously, from huge things, from finding a cure or a vaccine, to just being flexible with existing grants and allowing some of the grants to pivot and do some additional work. And so for that, I want to just already say thank you for those efforts and for your interest. We've also seen philanthropy helping to address first responder issues, providing community response funds. So again, your participation, your commitment, your concern, your caring, very appreciated during these times. So what I'm going to do in my time is I'm going to start talking about some of the overall issues that we're experiencing. And then I'm going to talk more specifically about children, adolescents, and families. And then I'm going to talk and offer what I hope are some thoughts about where philanthropy might fit in, and a little concept that I was teasing our panelist earlier that I came up with the other night about how to think about this. So the first thing I really want to start off with is about loss issues. And I think that many of us are experiencing, and quite frankly, we ache from tremendous loss of freedoms, loss of livelihoods, loss of connections, ultimately the loss of human life. And to address that, many resources have been developed and made available for coping with what has become the mental, educational, physical strain of this crisis. And so many wonderful resources, which are to be applauded. Many of you probably supported some of these things, and countless people across the country have found help and assistance, guidance, and even solace in the materials that are being provided. What we know from a lot of the information that's being generated across the country is that a large swath of America is having trouble with their mental health. There was a recent Kaiser study that said that about nearly half of adults across the country are saying that they are tremendously worried about stress due to the coronavirus pandemic, and they believe that it's hurting their mental health, which I will say is a real early and important sign that the health and economic crisis that we are experiencing is likely to significantly increase mental health problems as we go forward, and the entire system's capacity to deal with this. We also know that there are very specific populations that are being disproportionately impacted, whether it's communities of color or older adults, as we have certainly seen. I know I've personally taken advantage of going to the grocery store early, as an example. And those groups are at risk for poor mental health consequences, particularly from things like distancing, the social distancing policies and things like that. Even while we are opening up some, that this is still going to be significant issues. And we know that from a huge body of literature about things like social isolation and loneliness, that this impacts and creates poor mental and physical health. In fact, I had been reminded that a former Surgeon General I had the opportunity to work with, Vivek Murthy, had actually wrote a big piece about loneliness and its public health, it being a public health epidemic. And this happened even before COVID. So we know that poor mental health outcomes are associated with so many of the current factors that we're experiencing just right now. And then if you add to those kinds of issues, the economic stress that people are having, job loss or certainly reductions of income, and unemployment. We know that unemployment and poverty are significant factors in addressing mental health issues, creating more depression, more anxiety, which can lead to a host of very serious concerns like domestic violence or intimate partner violence, like child abuse and death by suicide. It's interesting that at my agency, I am a regional office of the Meadows Mental Health Policy Institute located in Dallas, and MMHPI has recently published a modeling study based on this concept of an economic recession, a COVID recession. And they took data, and I know that some of the folks that were very involved in this can provide more details than I can around methodology and the modeling. And ultimately, I think that our CEO, Andy Keller, would say that we're the first ones to say, we hope we get this wrong, that because modeling things can be, inaccurate. But based on recession level data that was captured, which includes the early recessions in the mid 2000s, and the idea here is to take data that was done between 1997 and 2010, and packaged that to see for each percentage point increase in the unemployment rate can result in a 1.6% increase in the suicide rate, which means that if we had a recession sort of on par with what happened in 2007 to 2009, where the US workers experienced a 5% increase in unemployment, it could result in the loss of nearly 4,000 additional American lives to suicide because of this unemployment alone. And to the extent that these relationships are somewhat linear, we know that for each additional percentage point, so beyond 5%, some people have actually talked about 15, 20%, that it could be approximately 775 more Americans die by suicide for each one. So I say all of this because I think that that can lead us into some areas where we might be interested. And I'll put in the chat box when I'm done some links that you can find related to this and some of the details. And all of that is going to have a major and significant impact on children and adolescents. And so I'm sort of creating a big broad picture, funneling down now to what we're worried about around children and adolescents. And from my perspective, the first thing we do is to use a trauma focus and a developmental approach. I say trauma because, when I was at SAMHSA, we define trauma as an event or a series of events or circumstances that really is experienced by the person that can lead to emotionally harmful or even life-threatening, adverse kinds of impacts on mental, physical, social, emotional, spiritual well-being. I mean, trauma is a lens that we know because of our history, and many of you are probably familiar with the adverse childhood experience studies that link a direct correlation between these negative experiences and poor outcomes, such as depression, anxiety, post-traumatic stress disorder, and also physical health outcomes like coronary artery disease or diabetes. And we know that the kind of trauma that we're experiencing right now, especially in my area in Houston, where we've had hurricanes and school shootings, that it's cumulative, that it really does build on, and we may not know this for the weeks, the months, the years to come. So trauma and its impact can really be a long-term. So we have to take a long-term approach. So that's sort of an important thing. We also know that it impacts children developmentally across different ages. So the manifestation of trauma, of anxieties, of all of the kinds of things that are happening right now with the different factors impact preschool children differently than, say, adolescents or children of middle age, like 6 to 12. So preschool children may have trouble more with separation, more temper tantrums. You get a little bit older and children may start to feel more irritable or have stomach aches and headache kinds of things, or become more aggressive. And in adolescence, we might see more physical manifestations, significant sleep disturbances, changes in appetite. So we know that all of these things can happen, and that many folks are really looking at, okay, well, how do we handle or how do we address that? I know in my agency, we, of course, as many have, a COVID-19 page. We created a parent tip sheet. Again, I'll put that link in our chat box in a few minutes. And I'm actually proud of us. We got it translated to Spanish pretty quickly if folks are interested in this. We've also started a Facebook Live and Instagram Live series where we talk to folks and answer questions. And we have a series for first responders about their mental health issues. So all of these things, I think, are critical components about the background of how we're now understanding what's happening from these different lenses, developmental and trauma focused. And now we want to think about ways that we can handle things. So the framework that I used is sort of a lens of the 4 Ps for philanthropy that you might consider when you all are thinking about your next steps: policy, program, provider, and person. And I did that because it helped me, mostly because it helped me to better understand what some of the issues are. But and how now, having worked with philanthropy, I can tell you that the idea that some philanthropy organizations are very interested in the whole policy area. And so for me, that is tantamount to important issues like telehealth. So how do we get involved, or what we do? We see right now the expansion of telehealth across the country, telemental health, in significant gains that have been made. Recently, CMS, the Centers for Medicaid and Medicare Services, have issued a statement and guidance saying that you can do telephonic services and get reimbursed as well. We need sort of, to educate folks that we can't lose those gains that have been made. That's going to be significant going forward because it increases access, it expands capacity, and the outcomes are really good. And most of you know who know teenagers, it's actually a better way they prefer this way than going to an appointment and taking all this time of sitting in offices. This is, they bring out their phone and we can provide services this way. So yeah, are there strategies to invest in, telehealth policy, domestic violence and child abuse, another one. The same way that my agency did this modeling related to the deaths by suicide and substance use, we're now in the process of looking at that for child abuse and the expansion. And we need to prepare for that in the future. Another policy area to focus on is around primary care and integration of behavioral health and primary care. Pediatric primary care offices is the place where 75% of young people go when they have a mental health challenge. And so if we do a better job of propping up primary care providers and having them connect to this, to behavioral health, then we're going to be able to do a better job of identifying mental health issues in children and then getting access to care and the services. So those are things that I think are really critical, because we know that 50% of adult mental illnesses are actually manifested by the age of 14 and 75% by the age of 24, which is why we often will say that mental illness is a pediatric illness. So by taking that approach, primary care, creating systems of care. Some of you may have, my former program at SAMHSA, some of you may have systems of care in your states or communities. Philanthropy and public-private partnerships to better engage and create a coordinated network of care, another great opportunity for philanthropy. So in the policy area, I just threw out a few ideas, telehealth, domestic violence, child abuse, systems of care, integrated care, all possibilities. In the program and provider support area, I've focused on several specific things. One, public awareness activities. My agency has something called OK to Say. We're actually sponsoring right now. We have during Children's Mental Health Awareness Week, we have purchased for our community 1,000 views of the documentary film Angst to come into your home. It's an IndieFlix documentary about anxiety and mental health issues with interviews of children and their caregivers. It's really about for 10 to 17-year-olds. And Michael Phelps makes an appearance. And we have a discussion guide that we came up with it. So, these are ideas. Suicide prevention programs I mentioned before about death by suicide. Getting involved with supporting protective service workers or foster homes, adoption agencies, community-based organizations and residential treatment programs and faith-based organizations that might be, at this time, both challenged from financial and being sort of overwhelmed with the amount of activities going on, but also wonderful ways to connect philanthropy with supportive services in the area of programs and providers. And then the last one I'll mention in this area is schools. Now, this is going to be the focus of some of my colleagues' remarks, and they are doing some amazing and innovative work in schools. I will say that we must help schools address what is likely going to be a significant pent-up demand for services and supports. The transition back to school is going to be tough. One of the reasons we're sponsoring the film Angst is to get parents and caregivers talking with their young people about, mental health issues and anxiety, because as folks go back to school, they're going to feel this more and more. We're also going to have probably more mandated reporting as things happen that we were not sure about, and supporting those school-based mental health approaches are really critical. We work very closely here at the Hackett Center with a Texas Regions Education Service Center, and created this idea of an emotional wellness implementation strategy, where we're trying to link and help them to link their activities with local community providers and really wrapping around services when they need them. And Dr. Coley is going to talk about a really novel program of use of telehealth. And then my last thing I'll say is person level support. Philanthropy directly for the people, which is happening. Philanthropy for first responders or people impacted by job loss. Or we see this around the restaurant workers or hospitality industry, and food donations and technology donations. This is a personal perspective but I see also what is lacking is a support for the tens of thousands of families who've lost a loved one to the virus. These are families that are really grieving, may have guilt associated with the idea of a virus. And so I think that we have to be in a position to support these survivors. And the idea here is that if they feel guilt for having passed it on or for not getting help, soon enough, providing treatment, therapy, support, services, etc. So all of those are kind of things. So that was sort of my overview, along with some very specific thinking, depending on what your mission and vision is, whether you support policy or programs or providers or persons, and then thinking about how you might be able to help during this time. And again, I'm just so appreciative to share that and to help you all think through this. And so with that, in my overview, I'm now pleased to turn the presentation over to Dr. Roshni Kohli from the Dell Medical Center, who's going to provide more details about the innovative program in Texas. So thank you all very much.
Thanks so much, Dr. Blau. It's such a pleasure to be here with you all today and to talk about something that is near and dear to my heart, and I think to all of us here, really talking about increasing the access to pediatric mental health care. So some of you may or may not know, Texas has been sort of towards the bottom of the country in terms of pediatric mental health care and our funding. However, during this last legislative session, there was a hallmark bill called Senate Bill 11 that funded just under $100 million for pediatric mental health. And we're looking at this in funding two different types of programs within Texas. The first one is the Child Psychiatry Access Network, which is a telephone consultation line that helps to increase the comfort for pediatricians that are caring for children and adolescents in the primary care setting where they're seeing a whole host of different behavioral health concerns. Pediatricians will be able to have real-time access to a child psychiatrist or a child psychologist, and they'll be able to really hear, just get real-life consultation, hopefully to increase our comfort with behavioral health. The second program, which I'm going to spend the majority of my time talking about today, is the TCHAT, which is the Texas Child Access Through Telemedicine. And this is an innovative program that uses telehealth to really reach children in schools. So if we think about schools in general, children are spending about 50% of their waking hours in the school setting. So school is the natural place in which to provide more access to mental health care concerns. School is the place where we oftentimes see behaviors arise. We oftentimes see children and adolescents struggling for a variety of different reasons. In the COVID pandemic, one of the challenges has been that children and adolescents are not in schools. And so for some, we're seeing a little bit of a decrease in anxiety. For many, when there is so many challenges in terms of not having that normal routine and that rhythm, many of our children and our youth are struggling. And many of us are anticipating that it is going to be a challenge when school comes back in session. As Dr. Blau mentioned, we are already seeing an increase in child abuse and domestic abuse. We are expecting that there will probably be a surge in mental health crises as children reintegrate back into school. So we want to be proactive. So what TCHAT does is each of the medical schools within the state of Texas, they all have their own hubs. And through these hubs, our hub is Dell Medical School, and we work through Dell Children's Medical Center. Our hub is going to be responsible for Austin and the Central Texas area. What we've started doing is already integrating with schools and meeting with different school districts and just starting to talk with them about what are they seeing, what are their mental health concerns, where do they feel like their youth are struggling. And then the second step is really looking at how do we make sure that we're partnering with community partners to make sure that this isn't just a one-time intervention, but that for the youth that really need mental health care, we're providing a continuum of care. So partnering with local agencies, partnering with our local mental health authorities or our community mental health clinics. What TCHAT offers is 1 to 4 sessions of diagnosis, evaluation, and treatment. So the way that we would get our referrals is through a liaison at the school. It could be their head of counseling. It could be a school mental health counselor. It could be a teacher, or it could be a principal. Oftentimes, what we envision is that there will be a team of folks at the school that will help to identify youth that are struggling and could use behavioral health assistance or care. And they'll then make that referral to us, and then we have our team of child psychiatrists and child psychologists that will be able to respond to those calls. We'd be able to provide some scheduling so that they can schedule that 1 to 4 sessions, and then we'll coordinate with the school, with their pediatrician, with the school nurses. So the idea is that, the schools oftentimes have a really good idea of how youth are struggling and what kinds of things can help. So we don't want it to just be an intervention where we provide some therapy services and hope that things get better. Rather, we want to have an impact on this child within the entire school setting. So working with teachers and counselors so that some of the things that we work on within those therapy sessions and those interventions, they can then be disseminated throughout to the individuals that are most involved with that youth. Following those 1 to 4 sessions, the idea is that we really want to look at how do we make this sustainable within the community. So one of the things that we've done through the medical school and through the Children's Hospital is really looked at partnering with our community mental health clinics so that they can continue to get the care that they need. If they've been seen by a child psychiatrist for consultation, the idea would be that we would work then with their pediatrician to ensure that they could continue to receive those services if they need more medication treatment, evaluation, or adjustment of their medications. The other thing that we're looking at throughout the schools is really looking at some things for prevention. How do we improve resiliency in kids? In this particular time, we know that our kids and families are struggling. So how can we equip our teachers, our mental health counselors, our principals, and our school administrators to feel like they have the tools that they need in order to really give the children and our youth the best care that they need? So looking at things like trauma-informed care, looking at things in terms of which they can improve their mental health first aid or their mental health knowledge and feel like they have the tools in which to be able to address things for our children and youth. One more note about the services in terms of the schools itself. One way that we've looked at it is to look at a concept called the 5 S's. And so this is really looking at what kinds of things are we looking at? How do we know that a youth is struggling? So we may look at first, concerns about safety. Make sure that there aren't any concerns in terms of potential suicide or self-harm or self-injurious behavior. Other things we'll look at are specific behaviors. What kinds of behaviors are causing complaints? And then the setting, where are these behaviors happening? Are the youth struggling at school, at home, at both places? And then trying to really delve into the stressors. Are there specific stressors at home? Is there potentially divorce or housing insecurity or abuse or other stressors that could be impacting a youth's the way that they're functioning overall at school? And then finally, looking at services. What services have been tried up until now? We don't want to reinvent the wheel. We really want to look at meeting kids where they are and figuring out where we can be the most helpful and provide the most strategic interventions. we talk a lot about children and youth and investing in our children because they really are our hope and they're building that future. If we can spend some time really investing in the mental health for our children and our families, we're going to see those effects for a long time in the future. So I appreciate all of your time today. It's been such a pleasure to be here today, and I'm going to turn it over to Dr. Adlon.
Thank you very much. It's a pleasure to be here as well. Thank you for having me. I'm joining you from the Department of Psychiatry at Massachusetts General Hospital, although as you can probably see, I'm more accurately joining you from my living room, like most people these days. I do want to remind folks, the host asked me to remind you all to please type into the Q&A function. I see somebody just did. So if you have some questions or comments for all of us, we're going to save some time at the end. So please type those questions in there. I'm actually going to share my screen and just share a few slides for a moment, because I know it can be hard to stay focused on a call like this. I don't want you all dissociating too much the whole time. So I'm going to give you something else to look at besides me for a moment here as well. I direct a program called Think Kids in the Department of Psychiatry at Mass General Hospital. And at Think Kids, what we do is we focus on helping kids, youth, adolescents who exhibit behavioral challenges. And even before the pandemic, it was a great challenge to meet the needs of these kids, primarily because these kids are often misunderstood. You see, most people tend to think that when kids exhibit behavioral challenges, and these are kids with a range of social, emotional, and behavioral issues, most people think that when kids exhibit these behavioral challenges, that they're lacking the motivation to behave better. In other words, that their behavior is aimed at getting things, getting out of things, avoiding things. And that sets in motion the use of all kinds of rewards and punishments, consequences to try to motivate more compliant behavior. And that's true in homes, it's true in schools, it's true in treatment settings, all kinds of places, despite the fact that there's about 50 years of research in the neurosciences these days that shows beyond the shadow of a doubt that these kids actually don't lack the will to behave well. What they lack are the skills to behave well. And so a big part of our work is helping the adults around these kids, parents, teachers, clinicians, to understand that the issue is about skill, not will. And the types of skills that I'm talking about are things like flexibility, frustration tolerance, problem-solving skills. Now, one of the things you'll probably notice right off the bat is in a time like this, these are skills that are even more in demand. I think, in fact, all of us are finding, even if we have good skills in these areas, that our skills are being taxed because we're being asked to be much more flexible and adaptable than usual. We're asked to tolerate much more frustration than we used to. And we're having to do all kinds of problem solving as we work from home, as we try to help our kids to stay connected in school, at home, as we deal with health challenges. These skills are in great demand. And this is one of the sad ironies. Actually, there's a couple sad ironies. One of them is the kids who need these skills the most right now are often the kids who are lacking in these skills. And that's because one of the primary causes of lagging skills in areas like problem solving, flexibility, frustration tolerance, is exposure to chronic, overwhelming stress, what some have called toxic stress or trauma. We know from imaging studies that exposure to chronic stress and trauma, like a pandemic, literally arrests brain development early on for children. And what that manifests itself as downstream are these lagging skills. And you don't have to be a neuroscientist to tell the difference between these two brains you're seeing in front of us in the scanner, a neurotypically developing toddler on the left and a toddler who is subject to some deprivation on the right. And you see massive differences in brain development. And of course, what does that manifest itself as? Difficulties with problem solving, flexibility, frustration tolerance, which downstream looks like challenging behavior. Now, even before COVID, one of the big problems is how people tended to respond to these behavioral challenges. And I refer to this as the cycle of chronic stress or trauma and punitive discipline. Because here's what happens. You see, kids who are exposed to chronic stress and trauma, as I just explained, that causes their skills to not develop the way we'd like, which leads to challenging behavior. But here's the big problem. That challenging behavior is most frequently met with punitive discipline, whether that's in homes, schools, or believe it or not, even our treatment settings. And the reason that that's such a tragedy is what punitive discipline does is add more stress, which further delays skill development, which further escalates challenging behavior. And unfortunately, how do parents, teachers, clinicians tend to respond when challenging behavior escalates? With more punitive discipline. In other words, upping the ante on the punitive discipline, which again, in turn, adds more stress, further gets in the way of skill development, escalates the challenging behavior. So even before COVID, what we were trying to do is help interrupt that cycle of chronic stress and punitive discipline. Now you can imagine right now just how many kids exposed to the chronic stress and trauma of this pandemic are having a hard time applying the skills they need to manage their behavior. And as Dr. Coley was explaining just before I started to talk here, these kids are going to be coming back into our classrooms and schools with more lagging skills and more escalating behavior. And we better have something other than punitive discipline to do. And the same is true in our homes and our treatment settings as well. As the chronic stress of food insecurity, homelessness, health issues is hitting parents and kids alike, we're going to see escalations in lagging skills and challenging behavior. In fact, we already are. So what we need to do is we need to do something other than meet that with punitive discipline. And here's the good news, folks. There's something else we can do that I'm going to broadly call relational discipline. There are many forms of relational discipline. We teach one, as was mentioned in the introduction, called collaborative problem solving. Others are things like restorative practices that can be used in schools and treatment settings as well. And whether it's restorative practices, collaborative problem solving, or some other form of relational discipline, the great news is what our research and others have shown is that when you respond to challenging behavior with relational discipline, it not only doesn't increase stress, it decreases stress. And not just stress for the child, but for the adult caretakers, the parents, the teachers. And that in turn, not only doesn't get in the way of skill development, it actually helps buttress skills, helps to build skills. This is what we call buffering effects. And of course, as you get less stress and skills developing, guess what happens? Challenging behavior is reduced. And it's this nice positive cycle all of a sudden, because as challenging behavior reduces, it's even easier to apply relational discipline. I mean, in fact, it's one of the great ironies. It's easy to apply relational discipline with kids who don't need it all that much. It's the really challenging kids for whom it's toughest to apply, with whom it's toughest to apply relational discipline. And the reason for that, by the way, is that dysregulation is contagious. When a kid gets dysregulated, starts to escalate and exhibits challenging behavior, the adults, we often go right there with them. But when we can stay calm and apply relational discipline, decreases stress, builds skills, reduces challenging behavior, and around we go. One of my favorite findings is that when we have worked with parents to teach them relational discipline, the other interesting thing happens is not only do the kids develop skill, but the parents do as well. It turns out that yes, you can teach an old dog new tricks. Parents like me at midlife, we can be shown that we can develop skills. We can literally develop neuropsychological skills, neurocognitive skills like empathizing, your perspective taking, things like that. Now, I'm aware that this term relational discipline that I'm using may seem a little abstract for folks. So I just want to delve a little deeper into it before I come to an end with my remarks and we have some opportunity for Q&A with all the panelists. The thing we try to do with relational discipline is to respect this sequence of engagement that you see in front of you. And these 3 R's are things that a good friend of mine, a colleague who's a noted trauma researcher, Dr. Bruce Perry, teaches. Regulate, relate, and reason. You must do those in that order. You can't reason with a child or an adult who's dysregulated. You have to regulate them first, then you can relate to them. And only when they're regulated and relating to you, can you reason with them. And the reason for that you have to follow that sequence is it maps onto how our human brains process information. You see, information hits the bottom of our brain first. And only if we're regulated can that information move up to the area where we can experience emotions and relate to people. And only if we're relating to people and still calm and regulated can we access that smart part of our brain, the prefrontal cortex, that helps us reason. That's the part of the brain where we do problem solving. That's the part of the brain that helps us be flexible. That's the part of the brain that helps us to tolerate frustration. All those skills that I talked about with you earlier. So the point is, if you're going to try to reach that cortex to problem solve with somebody at home or at school or you name it, you got to go in through the bottom of the brain. So for instance, when we teach people our approach to discipline, it starts with empathy. It starts with listening hard to the child's concern or perspective about the problem at hand. And only once the child is empathized with, so they're regulated, does the adult share their concern or perspective. Not their solution about a problem, but their perspective. And when you have 2 sets of perspectives on the table, you're doing full-on relational work. You're moving up the brain. And only then do we teach the adults to invite the child to the problem-solving table, to invite them to try to generate solutions to a problem that will address both their concerns and the adult's concerns. And if at any point in this process, a child or an adult gets dysregulated and goes right back down to the bottom of their brain, we just teach the adults to go right back there with the child, re-empathize with them, calm them down, and move up the brain. So that hopefully just gives you a little bit of a snapshot of what I mean when I talk about relational discipline. And again, the good news is when you apply relational discipline, you decrease stress, you don't add to it. You help kids build skills as opposed to get in the way of them being built, and you reduce challenging behavior. Now, in my view, there are many, many places that relational discipline can be applied. Obviously, in our homes where we are seeing escalating rates of abuse, and I can only imagine how horrifying those numbers are going to look once kids are out in public again, visibly being seen. But they can be applied in schools. Traditional school discipline is about as archaic and inhumane as it comes. It flows from completely outdated ideas about what leads to challenging behavior in the first place. And it's really time to entirely rethink school discipline. Many of our therapeutic approaches, as I mentioned before, in places like residential treatment facilities, in need of a major overhaul as well. Using point and level systems, sticker charts, things like that, they not only don't work for the kids to whom they are most applied, but they are the exact opposite of what is considered to be trauma-informed or trauma-sensitive. Trauma-informed practice, trauma-sensitive practice means not using a power differential to try to impose your will, but rather collaborating with the kid so that their concern or perspective is addressed as well, reducing the power differential and focusing on empathy and regulation first. Now, as I conclude my remarks here, I just want to share very quickly what we are doing in the midst of the pandemic. We have tried to move all of our training, all of our support for parents, teachers, clinicians online, which has been a massive undertaking and certainly hard in this climate to bring to scale when so many kids and so many families, and come fall, so many classrooms are going to need this kind of support. But that's what we're trying to do at Mass General Hospital in our Think Kids program. And the last thing I'll leave you with is the philosophy behind our work, which I think is even more important today than ever. Applied to kids, the philosophy is kids do well if they can, which stands in stark contrast to the notion of kids do well if they want to. You see, we believe all kids want to do well. And if they could do well, they would do well. And if they're not, it's about skill, not will. And our job is to partner with them, help them build those skills. And today, in the middle of this pandemic, I would just remind everybody that you can apply that philosophy to adults as well. Parents do well if they can. Teachers do well if they can. We are all doing the best we can to manage a very challenging situation with the skills that we have. But if we're not managing it well, let's not resort to rewards and punishments. Let's figure out the skills that are lacking and partner with people to help them develop those skills. So thanks so much for having me, folks. And I'm now going to turn it over to Anna, who is going to help facilitate the Q&A period with my fellow panelists as well.
Well, thank you so much. And it's just so exciting to hear that you're able to get these programs online, Dr. Ablon. That's wonderful. I wanted to mention, we're starting to get some questions in through the feed, which is great. And in addition to questions, if there are just some really great programs online that are working for you, that you are supporting your grant making right now, that you want to share with people, please feel free to kind of pop them into the chat, pop them into the Q&A, because we really do want to start sharing information with each other. So, you know, Dr. Blau brought up telehealth as a major policy strategy, and many of you have been working on that for a long time. We're gonna have a separate call just devoted to telehealth, because so many of the emergency telehealth orders that have been going through are really things that we could be doing all the time. And so there's a real effort now to get some of these emergency orders and make them permanent. And we're going to be having a separate call on that. But I also wanted to just mention that when I've had some conversations with some of you one-on-one, you've been sharing with me, and I'm thinking of one conversation in particular, that some kids don't even have, you know, an iPad or a desktop computer in their home. And so, you know, this telephonic support, it can be a really, really strong way to overcome that, even just having a phone therapy session with a child. And I do see that Dr. Prim has joined us, who's a medical director with the Steve Fund. She has a question which I'm going to read. And Dr. Prim, if you are one of the people who mentioned to me the whole issue of the telephonic support for some of these kids, if you can remind all of us, if you can type in the name of that program that you were mentioning, that would be terrific, and I will share it with everybody else on the call. But Dr. Prim has a question which she directs to Dr. Coley, and she says, Dr. Coley, will it be possible to provide telemental health services to school-age children in their homes in Texas, given the relaxation of restrictions on this service since the advent of the COVID-19 pandemic?
Dr. Prim, that's a great question. And yes, I think one of the things that we've seen that has been a really positive thing in this pandemic is that the legislation regarding telehealth and telephonic services have really relaxed. And so, you know, we have been able to provide telehealth services into homes right now through our Dell Children's Medical Center, and we anticipate that we're going to be able to continue to do that through the schools. So if, for instance, school is not back in session in the fall, our plan is to really go in to be able to do telehealth encounters through patients' homes. And also recognizing that, you know, in some of our discussions with the schools, they really state that for a lot of children and families, it's really after hours and weekends in which they feel like those behavioral health sessions would be the most useful. And so we've really been talking to folks and problem solving, is that an option as well? What Dr. Ablon was saying is, you know, we want to engage not just the child, but the family. We want these services that we're providing for children to have an impact for the entire family, so that we really see those benefits at home and at school.
Great. Thank you. So we have another question that I think is probably on a lot of our philanthropists' minds, and I'm not sure if it's a question for Dr. Ablon or Dr. Blau, but the question is from Fred Frankson. Until COVID, there was a lot of buzz and attention paid to the inclusion of the social and emotional learning in the schools. How is what you're discussing, does it integrate with this, or is SEL something different?
It's a great question. I'm happy to take a stab at answering it, and Gary can back me up and get anything I missed or correct anything. Yeah, there was a lot of buzz about SEL, social emotional learning. The things I was talking about could certainly be considered social emotional learning because they are helping students to develop social emotional skills. When people talk about our social emotional learning in schools, generally they're speaking about trying to focus on these skills for all students. Some of the approaches that I was describing are particularly oriented towards what in schools we often refer to as the top of the triangle kids, the 1 to 15% of a student body who are most at risk. The nice thing about relational approaches, like I was describing, is that they are I would say, necessary and life-saving for those kids at the top of the triangle, but they start to filter down to all students as well. Because there's not a kid who can't use some practice in areas like flexibility, frustration tolerance, and problem solving. So the integration is right there, and these would be termed social emotional learning programs, but they are oriented at some of the most at-risk students in particular as well.
Yeah, and I would echo that, and of course support my friend and colleague there in Massachusetts. I think, I tried to on one of the Q&As to actually answer this idea about what are the frameworks for integrating mental health, behavioral health in schools, and one of them is a framework called the multi-tiered system of supports, and the idea that what Stuart was just talking about is, in general, social and emotional learning are typically identified as a tier 1, sort of more of a universal approach, and then as you go up to tier 2 and then ultimately tier 3, you're talking about more focused approaches and then more specific approaches for a population that might have a very specific kind of disorder. So I personally would say that that this is part of an overall approach, an overall sort of conceptual framework from social emotional learning in general, through the idea of focused interventions all the way through very specific and targeted interventions for children that have specific disorders.
Okay. So we have another question, which Pat Weir asked us, do certain programs have a better use and efficacy in public schools versus private school versus homeschool? And I think she probably means the teleported programs as well as just content in general.
You want to go ahead, Dr. Coley?
Go for it. I can go in right after.
Well, I was just going to say the programs that I'm familiar with, including the program that we teach, we can't make any generalizations about differences across these settings. What we can say, and this is true of any evidence-based practice, is it's all about implementing with fidelity and sustainability. And public schools can do a wonderful job of implementing with fidelity and sustainability. And so can private schools, and you can do them at home as well, but you've got to follow best practices from implementation science. And I think, that's one of the things I like to emphasize with folks is even the best approach, it's not magic. It requires training, it requires coaching, it requires creating local experts who can carry that culture on if it's going to be done well and sustainably.
Thank you. We have another, this is a detailed question I'm going to read from Amy Gorn, who's writing from the Mat-Su Health Foundation in Alaska. She says that they've been funding local providers to work in their schools, and they've developed core implementation teams for implementation regarding their referrals and immersion to reduce stigma. It sounds quite similar to Texas. Questions. Telehealth during the pandemic is an amazing option, but we're seeing a drop-off as we surmise at-home conditions are just not ideal for youth and children to have space and non-chaotic time to continue services with video. Have you seen this? And then she also says, as a private funder, we allow funds to support non-billable ancillary and helpful services like clinicians attending staff meetings, school family nights, checking in briefly with students. Do you include these services in your programs, and how is it paid?
I can take that. Those are some great questions. So Amy, we are, for right now, actually in the state of Texas, we've had a lot of difficulty in terms of telehealth for psychiatry, psychology. It really has never been approved to the level that it's been approved until right now in this COVID pandemic. So as a result of that, we've been able to see a great escalation in telehealth services. And what we're seeing for many of our patients that are just in our general clinics at Texas Child Study Center at Dell Children's, for instance, we're seeing that for our kids and our families, they're really enjoying telehealth. We've actually seen an increase by 100 encounters over this last month. Many of my clinicians are telling me that for our kids who have social anxiety, who really struggle coming in for appointments, those kids are actually really benefiting from being able to do a session from home. Now you bring up some really good concerns that this isn't going to work for all families. For all families, they may not have a place that feels less chaotic where they can really feel like those kids can get the services that they need. And so I think we need to be flexible and adaptable for the child. We need to meet them where they're at. So for some kids that may be better in a school setting or in a pediatrician's office, and for some that may be at home. I think from a legislative standpoint, policy standpoint, and then as well as when we're thinking about clinical care, the best thing that we can do is really to be able to, now that we have this telehealth access, to have it continue to the degree in which it's really helpful for our families. In terms of your second question, in terms of the non-billable services, through TCHAT and through Senate Bill 11, right now we have the ability to really work with teams at schools and to do some sort of consultative non-billable work. The only way that will be able to continue in the future is either one out of other grants or philanthropic manners, or if there are continued efforts from legislative funds. And so the non-billable work is probably one of the most challenging to fit in terms of many of the current clinical structures and programmatic structures that are out there, but they're so vital and so important. So the more that we can incorporate that, I think we really see the benefits for schools.
Thank you, Dr. Coley. Thank you to all of the three doctors who joined us today. We really appreciate this. This time has flown, but we are reaching the end of our time. We want to continue this conversation. It's something that we've been working on for a while, and we're looking forward to developing a small strategy group to just continue to talk about these topics during COVID, to brainstorm about the very best investable opportunities for right now. And we're looking for ideas and for information sharing from all of you. So I will be in touch, and please be in touch with me as well. Just, email me if you want to participate. We'll also try to send out a Google or some kind of a survey after this call to solicit your interest in joining us for that strategy group. I wish we could, luckily there's many more times we'll have to talk about this, but thank you so much to our panelists, and I want to just express my appreciation for them taking their time to share their learnings with us, because this has been just fantastic. So thank you, and we will talk again. So thank you.
Thank you.
Thank you so much.
Thanks, everybody.